Groups are a very interesting topic for some of you, especially in this class. You've experienced at one time or another a group in a clinical setting as part of your work profession. Group is a way to help patients recover. It helps them to better understand themselves and the effects of how their harmful thoughts or feelings can affect them in their lives. So when we're thinking about characteristics that influence a group, we're thinking about the size, what the defined purpose is, the degree of similarity among the members in the group, and rules that affect the group that include confidentiality, structured times, rules, and respects. You really need to look over this slide because it's important to understand that the size of the group, the type of group determines the size of the group, but it's important, especially in that orientation phase, for everyone to know what the purpose of the group is, and then the fact that within that group, based on the type of group that you have, that you're going to have members in that group that have similar exposure to whatever is being discussed, the topic that's being discussed, and will have a lot of input when it comes to like formulating and getting together to discuss information within these groups. Other characteristics added to that also include the boundaries that are set for the group, what content is going to be discussed, and the process through which the information or the dynamics of that group is going to be. The therapeutic factors common to most groups, there is the installation of hope, and I've included some information in here. And how you'll see this expressed with a patient is when they say that this experience allowed me to get in touch with my sadness. That's how you know that that has worked for them. With universality, the members realize that they're not alone with their problems and their feelings and their thoughts. With imparting information, the participants receive formal teaching by their leader or advice from their peers. And so that might be displayed as here's how to take your medications. Imparting information happens, and that's really more with that education. Again, and that really comes from the nurse. With altruism, which is definitely something that you need to remember, this is where members gain or profit from giving support to others. And so it ends up resulting in a better improved self-value. So you may hear patients say, I'm sorry that happened to you, or you may say, I'm sorry that happened to you, I can help you. With corrective recapitulation of primary family groups, patients are given feedback of behavior about their family. So within a group, you may be able to detect that maybe a particular individual has a repeated behavior that they have. And you may hear another group, another member of that group say, is this the way you speak to your wife at home? So it kind of makes them reflect on their behavior, makes them look at themselves because they're getting their feedback either from the leader of the group or from an individual within the group. And then there is the development of socializing techniques in which the members learn new social skills based on feedback that they're receiving from everyone in the group, including the leader, but also role modeling. And most of the time that role modeling happens on the part of the leader of that group. So you may hear something like, you took that criticism really well, you didn't appear to become upset, maybe I can try that. So you'll see that within that positivity, you're seeing that role modeling as they're in groups. That's really what happens, is the problem solving, figuring out coping skills, and then changing that maladaptive behavior to be more adaptive. So with groups can be defined as a group if it has two or more people who are engaging in an interactive relationship. Doing in that group, there's a sharing of at least a common goal or issue. And the group is more than the sum of all the individuals that play a role in this group. It has its own personalities, it develops its own way of interacting, and there are rules of behavior. Now, when we're starting to discuss the planning phases of the group, that process starts with one, what is the name of the group? Are there objectives? What type of individuals are we expecting to be here? Is it just an all male group, all female group, only of a certain age? What schedule will they be meeting at? Is it once a week, every day, once a month? What is the physical setting? How are the seating arrangements going to be? What type of leadership is going to what type of leadership style are you going to see with this group and the members, and what are their responsibilities, and then the methods or means of evaluating those outcomes. Member suitability, you just have to think about a couple of questions, and we do this all the time in nursing, is when you're having a group, sometimes you have to look at everyone, because everyone has a right to treatment. We find ourselves a lot of the times having to look at the whole, I call it milieu, which is all the individuals of that group, to determine the best and if each member is suitable for the group that we're going to try to have, and whether or not we need to reconstruct maybe having a group, but then maybe there's a member who doesn't really fit into the group to allow it to be um, beneficial to everyone. We may have to take one individual out of that group and allow them to have a one-on-one session with a therapist while the group is going on, and that way everybody's getting treatment. So the things you need to be thinking about: does the purpose of the group match the needs of the potential members? Does a potential member have social skills to function comfortably within that group? Do other group members accept the new member, and what is the potential of the group member to commit to attending these group meetings? Then there are different types of groups as well, based on open versus closed group. In your open group, new members can join at any time, they can leave at any time. And new members, you'll find, are more at a disadvantage. But the advantage of this group is that this group can continue on and on and on, because you're always bringing in new people. And then once people have met their goals and they're leaving. With a closed group, the members join at one time. There's no new replacement members. The groups are more cohesive, and they're more likely to dissolve as soon as when members drop out. So it's a group that starts to meet a purpose, and once that purpose is done, it's over with. There are no new members, and so that's it. With group sizes, it's important to remember, and what you'll see is that with most group settings within a psychiatric unit, they're very small, so about 7 to 8 members. It's very cohesive. There's not a lot of subgroups. There's rich interpersonal experiences. There's usually 1 to 2 leaders, and it's ideal for discovering complex issues amongst the individuals that are involved. With a larger group, you're having more than 8 to 10 people. It's effective when you're dealing with just a special problem. It can be therapeutic. It's more cost effective. It's also like a more open-ended, ongoing thing, when you like, more appropriate for those kind of groups that you're going to have. And there's not a lot of transference or counter transference going on. And I think that's just because the more members are involved, sometimes not so much you get lost, but you don't get to focus on just one individual, and there's not a lot of interchange of that feeling upon. But when your groups are more intimate, you might find that transference and counter transference is happening more there. So a question: is the following statement true or false based on the information that we just went over? A small group is typically more cohesive than a large group. And if you said that thought to yourself while listening to this lecture, that the answer is true, then it is. A small group, because of its size, typically provides a more cohesive group, because the leader and members can't get to know each other very well. With group development, there are different stages to this. So we have your beginning or your, well, that's not really true. Let me go back. I'm going to say there's the pre-orientation phase. The pre-orientation phase is that moment in which you're getting to know your patient. It's that moment where you're reading about them, you've got a report about them, and you're making preparations to receive them. Then that orientation phase is really actually when you guys meet. That's where you develop that rapport. You create the basis for them to begin to trust you. So you're getting to know each other. This is where you, when you're forming that group, you're using those techniques for leading the groups. And then this is where your testing by members happen. This is usually where the conflict happens, right in the very beginning stages, because that's what people do. They test the group. They want to know how far they think they can go, but a lot of the time that's just a result of having anxiety. But this is where you also establish that contract with them. You establish the expectation that there's going to be confidentiality. You're going to have that structure of what the expectation is for the group, what time are they going to meet, how y'all going to communicate, and then everyone is introduced. In the working stage, that's exactly what it is. It's work. Now, why are you here? What is the problem? How are we solving it? That's when you start working on discovering what the patient needs. The sharing of ideas happen. There's the development of norms, and then the realization of the purpose. And then that's when the individuals in that group make a commitment to being in that group and they commit to one another. With group development continuing, we have that final stage. So we talked about pre-orientation, we talked about orientation, we talked about working. Now is that termination stage. And a lot of the times, like with patients, you got with patients where we're taking them into the hospital, that discharging or termination, that happens on admission. We have to be preparing them for discharge. If we know that they're leaving tomorrow, we start talking to them today, and more so because within a psych unit, you will have patients who the minute if they find out too late that they're being discharged, then they start having these separation feelings and may create reasons for why they're not ready to leave. But in that termination phase, there's going to be grief or loss of that closeness that you have in that group, that they're going to have that's where you're going to see that reestablishment of their self as an individual, because now they're leaving and expecting to take everything that they had in that group and be able to do it on their own, but not so much necessarily on their own. They're going to have some you're going to give them all the support that they need, and then you're going to have that summary and future planning. And so with that, you're thinking, okay, this is what we've done, this is what you've learned, this is how you're expected to input this into your life. And if things aren't going exactly the way you wanted them to do, or you need some support, we're going to give you all the references that you need. So question: a group is in the honeymoon stage of development or orientation phase. Which of the following will most likely occur? A, testing of members. B, sharing of ideas. C, forming a group personality. Or D, realizing the group's purpose. Now, I'm going to give an example here because I know that some of the students were having some issues on their testing, figuring out how they were going to work out these questions. So I'm looking at this and I'm going, realizing the group's purpose. No, the group purpose, that's really discussing a working phase. Sharing of ideas is working phase. Forming a group personality, I feel like is in the working stage, but the testing of members, as I said earlier in the lecture, that is where members go, well, how far can I go? And they do that on the very first day because of anxiety in that orientation phase. So if you're thinking A, because you ruled out B, C, and D as the working stage, let's see what the answer is. The answer is A. During the beginning or honeymoon stage, the members begin to test whether they can trust one another and the leader. Sharing of ideas, forming a group personality, and realizing the group purpose occurs during the working stage of the group. And what I just did help you guys figure out how to rule out something, rule out possible choices to kind of narrow down and get you to the right choice. We're going to try another question. Sorry about this. We're going to start all over again. Okay, so when looking at the next question, the next question is, which of the following comments made by members of a group best demonstrate a task role? Is it A, I want to tell how my problem started. I'm having more trouble than anyone else in this group. Is it B, 3 people were late for this group. Everyone is supposed to arrive on time. C, I can't believe you're talking about your failed romantic relationships again. Or D, we started out talking about guilt. Why are we not talking about his feelings? This is dumb. So as we'll talk a little bit further when we get into group members and what the task roles are. Everybody there has a role that they play, but with task roles, you're thinking about what is the purpose. So, or you're looking at um, specifics to information found in this group. So I want to tell how my problem started. I'm having more trouble than everyone else in the group. That does not appear to be a task role for me. 3 people were late for this group. Everyone is supposed to arrive on time. I can see that someone's trying to clarify the values for the groups that might be task oriented. I can't believe you're talking about your failed romantic relationships again. Does not seem to be a task role. That's more of a complaint. And then there's, we started out talking about guilt. Why are we not talking about his feelings? This is dumb. So I'm going to go with B, and let's see what that answer is. And the answer is B. 3 people were late for this group. Everyone is supposed to arrive on time. And so now we're talking about leadership styles. There are 3 different types of leadership styles. One is more direct, where you have your autocratic leader. They exert control over the group. They provide direction. There's little discussion going on. It doesn't really encourage much interaction. The purpose of the autocratic leader group, they tell the members what to do. In the indirect, the more democratic leadership, it supports interaction amongst the members. Everyone is engaged in problem solving. There's a balance of direction along with some group freedoms. And you'll see this a lot with your psychotherapy groups, so that's important to remember. With your laissez-faire leader, it's not always the great leadership, and so it has its place. So with this type of leadership, the members behave in any way they choose. There's no attempt to control the direction of the group. So you need that more in your creative groups, like arts and crafts or something like that. And there's little guidance or information to the group. Types of groups that you're going to find within the psychiatric field include psychoeducation groups. Remember this, please. It's formally planned. They increase the knowledge of social skills. This is where individuals learn new coping skills. And so an example of this, remember this, is anger management. With your task groups, they're focused on completion of specific activities. An example would be planning a menu for the week. This decision-making groups, that's where your group things happen. This is where individuals plan activities, develop unit rules, select the learning material, and you'll find within this that there's some type of charismatic leader here. With your support therapy group, this is less intense and focused on helping individuals cope with their illness. With psychotherapy, this one is usually done by a nurse practitioner or with someone who has a master's degree in training. In altruism, I told you guys, remember what that is. So go back and see that slide when you do. And with self-help groups, remember your self-help group is something like AANA. It is run by a person who has overcome the same problems as a member in the group. So actually, they're a member who suffers from the same problem was successful in uh, how can I put it? They were successful in going from being maladaptive to adaptive in their behavior, and now they're assisting other people with the same problems. So just remember that when you guys are answering your questions, okay? Now, the next thing that we're going to look at is other groups that include medication groups. Your medication groups are really about education on medication, and this is usually provided by the RN. With your health education group, it's education on a particular mental illness or condition or other physical health conditions. Outdoor diagnosis group. I don't know why a lot of students struggle with this. Dual diagnosis is learning about coexisting mental illnesses and substance use disorders. So that means they have two diagnoses, such as schizophrenia. There's also one called alcohol abuse. This is specific to the question in this class. Other groups can be your wellness group, your symptom management groups, your stress management group, your therapeutic community meeting groups. And these groups are usually made up of patients and staff to just talk about problems within their group. But just remember with it, I'm going to go back to dual diagnosis. That means that this individual has two diagnoses that are from a mental standpoint. So they have a mental diagnosis, and then along with that, they have a substance abuse diagnosis. So it's a mental illness plus a substance use disorder. You can get that. So schizophrenia with alcohol abuse. They could have bipolar with opioid abuse. So kind of think about that in that perspective, okay? Techniques in leading groups. In any group, you got to remember that your role as a nurse is to always be thoughtful and considerate by using the correct communication techniques, because this is going to impact how your group flows and the process. They need support. We have to think about confrontation, giving information through advice and suggestions, summarization, clarification, asking questions and probing, active listening with repeating, paraphrasing, and highlighting, reflection, empathizing. Where do you guys remember this from? You remember this a lot from your therapeutic communication, and with an emphasis on confrontation, so making sure that you're looking over that information to determine what that is. When you're putting your groups together, you're thinking about seating arrangements. So with that, is there space and privacy? That's going to be important, especially with depending on the type of group and the relaying of information. Are we removing barriers? Sometimes having tables creates a separation. So when you remove a table, it improves that communication flow that happens amongst everyone. Members are they able to see and hear each other? Sometimes having everybody in a circle group enhances the work that is going to happen. And those sitting close to the group leader usually have more power in that group. So if you're thinking about that with seating arrangements, if the person sitting closest to you has more power in the group, what type of individual should be sitting next to you as a nurse, or what type of person do you want sitting next to the nurse? Is it someone that might create barriers for others and affect their ability to benefit? So we'll talk about that as we go through future slides. When you're planning your first meeting, you need to think about the tone that you want, making sure that there's a proper introduction. Self-disclosure. Self-disclosure is okay, but sometimes you want to make sure that you're keeping back information because we don't know what the intent of everyone is in the group, and it's a protection for yourself. Explain the structure, the purpose, and the rules, and then engage in observation of the group dynamics, looking at verbal and nonverbal interactions within the group so that you can Factor the information to benefit everyone and the different type of members in your group. With group communication, you want to make sure there's a facilitation of not just the verbal, but also the nonverbal communication. Encourage interaction between each of the members and then engaging in that active listening. And with verbal communication, it's important to understand that that communication is that pathway to making adjustments and changes, and it's how you communicate what the group theme is going to be. When you're monitoring your nonverbal communication, you want to be looking at, again, seating arrangement. How should eye contact be? What is your posture, your body gestures, and in tracking that group communication? I will tell you that a lot of times in your therapeutic groups, that's where if you're paying attention to what's being said, sometimes there's these sideline conversations that are happening that give you insight into what's going on with the patient. It allows you to eliminate barriers to that person actually benefiting. So sometimes they'll tell you one thing that they're doing well with their medication, but they may tell somebody else the medication is not helping them. So you'll be able to eliminate some conflict in information in these groups. The role of each group member, and we're talking about this, and we're going to get into this a little bit from that previous question that we had. But remember, with your formal group, you're going to have your leaders and then you're going to have your members. With your informal groups, it's going to be about task, maintenance, and individual. So what's the purpose of the group? How is the group going to be kept together? And then what is the personal needs of everyone within that group? Group member task role. Everyone usually has a role. You'll have a mixture. Not all the time are you going to have everyone in this, but there's always that initiator, contributor that they offer new ideas or fresh outlook. With the information seeker, they like to clarify the group's values. Then you have that information giver that provides facts and shares experience. You have your opinion giver that shares opinions to influence group values. You have your elaborator that gives examples and follow up on meanings of those ideas. Your coordinator connects ideas and suggestions. Your orienteer, they note the progress of their group um, and how in the progress they're making towards those goals. The evaluator measures the objectives. Are we meeting them? Your energizer is that one that just gets everybody going, to encourage everybody to make decisions and take actions. Your procedural technician, they help the group with physical tasks like making sure everybody has their papers, where chairs are supposed to go. And then your recorder, they're the ones that's responsible for keeping notes and really is really the memory of the group. Maintenance goals. These are your encouragers, your harmonizers, your compromisers, your gatekeepers, your standard setters, your group observers, and your followers. So your encourager will praise and seek input from others. Your harmonizer, like, mediates conflicts. Your compromiser yields to keep the harmony within the group. Your gatekeeper monitors all members to keep communication open and equal. Your standard setter does just that. Your group observer just does that. Looks at the process, reports to the group, and your followers, they agree with the flow of the group. So now we're going to look at a question. Which of the following is considered a task role? Compromiser, group observer, elaborator, or encourager? So again, I'm looking at them and I'm going to try to rule them out. Now I know I just went over a slide that says that the compromiser is in the maintenance role. The group observer, and that could possibly be a task role. Your elaborator, that could possibly, no, my group observer My group observer is more of a maintenance role. My elaborator, that's a task role. And my encourager, yep, that's a maintenance role. So if you came up with the answer C, that it's elaborator, by ruling out A, B, and D, let's see what that answer would be. And the answer is C. The elaborator is a task role. The compromiser, group observer, and the encourager are maintenance roles. So hopefully you did a good job with that. What are individual roles within your groups? Now, some of these individual roles, they are more of the ones that can present a few obstacles. So you might have your aggressor. That one is always criticizing and attacking someone else's ideas and feelings. The blocker will disagree with and halt any group issues and feelings within that group. The recognition seeker seeks attention by boasting and discussing their achievements. Self-confessors verbalize feelings and observations beyond the scope of the group topic. Your playboy acts disinterested in the group process. Your dominator tries to control other members of the group with flattery and interruptions. Your help seeker asks for sympathy of group excessively. And your special interest pleader advocates for a special group with prejudice and bias. So, although you have these individual roles within your group members, it's still possible to have a therapeutic group that benefits everyone. The ones that are more challenging are the ones that we're getting ready to discuss that can definitely create bigger challenges. You're always going to have these selections of groups no matter what. And if you think about any group that you're in, there's always one of these individuals in the group. But this next slide we're going to talk about is where we're going to see these other challenges that can affect the whole group and anyone's benefit. So your challenging group behaviors includes that person who's monopolizing, and that person who's monopolizing talks the whole time. They can destroy a whole group because they don't understand what that process is. Your complaining member, who rejects help, they're always going, yes, but, okay? Going back to your monopolizers, understand too that what you need to do to help them is to provide them with a reminder of how that group works, and then remind them that everyone should have an equal chance to contribute. And then look into the reason for why they are monopolizing. A lot of the times it's out of nervousness and anxiety, and that's an important factor that you need to remember for evaluations, future testing. Set limits for each individual. That way you're not singling out the monopolizer, but then understanding that everyone gets 2 minutes, and that way everyone benefits from the group. Your demoralizing member is the disliked member. They're self-centered, angry, depressed. They don't have empathy, lack apathy, or hopes or concerns about anyone in the group or the group itself. They don't want to take any responsibility for their own actions and behaviors. They will be challenging to the leader, and they are going to be negative about that whole process. So what do? You listen objectively to that individual. Remember that the patient who is angry is vulnerable too, and that their behaviors of demoralizing and devaluing others just keeps them at a distance so that they don't have to think. But you still need to be mindful of this individual from a safety aspect. When we think about individuals who are angry, a lot of the times there's something deeper going on there. And so at any given point in time, they become a safety. They could be a harm to themselves or harm to someone else. And your silent member, they are the ones who are just observing intently until they decide if the group is safe for them, or they feel competent enough to be a part of that group. The problem with the silent member is sometimes because of how silent they are, they can get lost in the group and therefore are not benefiting from the education that's being provided. So, how do we address this? Help the patient to understand that any thoughts that they're having, any feedback that they have, can benefit someone else. The purpose is providing one another valuable insight. I was thinking, and then giving them time. That's the other thing. Give them time. Let them know that, we're patient. We'll wait for you. A lot of times it's uncomfortable. But again, the challenge here is that with these individuals too, they can get lost. And if there's a lot going on, because you think you got your demoralizing member who is angry and upset and is harm or risk to themselves, but your silent member, because you don't know what's going on in their head, they can also be a risk to themselves. So be patient with them, developing that rapport, letting them know they have time, but telling them that their input, it counts, it matters. So we have a question. Is the following statement true or false? Groupthink is a common occurrence in psychoeducation group. Groupthink. That's where people get together to make decisions. And psychoeducation is where they're receiving education. This is a formal planning. I'm going to say the answer is false. Let's see what we get. And the answer is false. Groupthink commonly occurs in a decision-making group when group members form opinions consistent with the group consensus rather than critically evaluating the situation. Psychoeducation groups are formally planned and members are purposefully selected. So hoping you guys were on track with that. So we've talked about our groups, we've talked about leadership, we've talked about members that might be a part of our group that make it interesting and creates a few obstacles or hurdles that we have to jump. And then we also have talked about the different members that can really create some barriers as far as distractions from the group or may present safety issues within the group or within that member. So now what are some common interventions that we're going to be doing? Medication groups is one. Symptoms managed group is another. Anger management group. Again, psychoeducation. Self-care groups and reminiscent groups. And so we're going to come up with a question next. Medication education and health educations are types of, and I just said psychoeducational groups. Or is it B, insight-oriented groups? C, support groups? Or D, psychodrama? And because we just went over that, you should have come up with the answer A, which is psychoeducational groups. So let's try another question. A group participant frequently reminds others of the group's main purpose. What type of role is this person fulfilling? Is it A, maintenance? Is it B, individual? Is it C, task? And if we go back to that earlier question that we went over, we have that individual that says 3 people were late. That's your task. Okay, and so the answer should be C. Let's see what that is. And that's right. The answer is C. And that brings us to the end of this lecture.